The next is about the vertebral column pathology. That again, the first of the thing is the low backache. Now, low backache is one of the very common disease condition, and it's all related to the lumbar vertebral pathology. So, before going into the low backache issue, we will discuss about very briefly about the basics of anatomy of the lumbar vertebrae. Lumbar vertebrae are unique in that sense that they have a vertical height which is lesser than the horizontal diameter. They are wider, and because of the width, they are supposed to be very strong. And lumbar vertebral bodies also are considered to be the strongest bones of the body. And if you go into the epics in Mahabharata, the Indra's Vajrayudha was prepared out of the vertebral bodies of the Diji. So that again suggests the Vajrayudha is supposed to be the strongest of the instrument. Anyway, the bone density of these is quite high because they bear the weight. Moreover, the structure of the vertebral body is designed in such a way that it bears the weight in the vertical direction. And unlike other animals, human beings are supposed to bear the weight in the erect posture, and there is a continuous instability of that position. The position of being erect is the most unstable position, whereas animals which walk on four legs, they have a more stable structure, and hence the human vertebral body is constantly under strain, where the body has to adjust to the gravitational force by this and avoiding that fall as such. Keeping in the vertical position is the unstable position, and there again the lumbar vertebral body has a major role to play in maintaining the position. The thoracic and the cervical segments of the vertebral bodies have a lesser weight bearing significance compared to that part as such, and hence it's meant to bear the weight. Moreover, the vertebral bodies also cover the whole spinal cord, the nerves as such, the spinal cord which passes through that spinal canal, as well as the nerves which come out through the nerve processes. So these also are one of the important issues, or one of the important structures related to the vertebrae, and they have a huge clinical significance from the point of view of the disease conditions. And the spines of vertebral body also are one of the essential structures to facilitate the contraction of the muscles. The paraspinal muscles, they use that spine as a leverage, and hence they act as the supports as such. So vertebral body's structure is of that sort. The vertebral column can be segmented into the anterior segments, the posterior segment, and the middle segment. The middle segment carries the spinal cord as such. Neurological structures are related to the middle column area. Each of the vertebral body is having two joints, like the one is the symphyseal joints. The vertebral joints would have symphyseal joints in the sense of the joint between the two vertebral bodies, which is having a fibrocartilaginous covering with the intervertebral disc in between, and this kind of joint is called a symphyseal joint, which is also a stable joint, but it allows for some movement as such. So there is a hyaline cartilage, and the vertebral disc, intervertebral disc, is in between. That hyaline cartilage covers it. So it's again a unique joint, which is something different from the other fibrous joints. Then in between the two facets of the vertebral body, there you have the facet joint, which is also quite critical, and this joint is a synovial joint, and it forms this joint between the inferior and superior surfaces of the adjacent vertebrae, and this also is called as the zygapophyseal joints or Z joints. Now, intervertebral this disc and this vertebral joint, symphyseal joint, helps in maintenance of some antero-posterior movement, whereas the facet joints they reduce the extension, they restrict the extension so that there is no accidental fall. So when the body is extended and flexed, the load is over the facet joints as such, and the facet joints would be restricting that. Moreover, in between the two facet joints, you have the foramen through which the nerves come through, and the neural foramen is actually not a real foramen, it's a foramen-like structure formed in between the space of the two facet joints above and below, and that's the passage through which the nerves come through. And whenever there is any strain on the facet joint, the nerve roots tend to get compressed easily. Now, in between you have the intervertebral disc space, intervertebral disc structure. That intervertebral disc also is a unique structure which has the nucleus pulposus in the middle, which is very soft and allows for some movements of in between, and surrounded by the fibrous layer, annular fibrous layer, and it has multiple layers. The intervertebral disc has multiple layers which allows for some amount of cushioning effect. It buffers the strain on the vertebral bodies because of that multiple layers over there, and this nucleus pulposus being somewhat soft gelatinous substance allows for some amount of the movement in between. At the same time also reduces the restriction, the resistance or the friction between the two vertebral bodies even. So when it comes to question of integrity of the functions of the vertebral body, the intervertebral discs have a major role to play there. Condition of these intervertebral discs also would be one of the criteria by which you can confirm like whether the vertebral bodies are functioning properly or not. Then the other stability of the vertebral bodies also is depending on the ligaments. So the whole issue is vertebral column has multiple different structures which decide about the stability, and when a patient comes with the history of pain, you have to consider all these issues. So from that point of view, these basics of anatomy are important, and whatever we are discussing is very basics, primitive issues of the anatomy. The ligaments again are primarily anterior, posterior and supraspinous, plus a ligament flavum which is present in between the interlaminar area interval. Now these anterior lumbar ligaments which are present over the area, which are a thick fibrinous layer connecting the vertebral body in between, they reduce the limit of extension, or rather they will prevent any sudden fall in the extension. Now the role of these are quite important in maintaining the stability in the resting condition. In the resting condition, when you stand erect, there is a constant force of the gravity which tends to make the body move forwards or backwards. Now these movements are blocked by active contraction of the muscles, but at the same time the position is stabilized, maintained by these ligaments. Anterior ligament prevents a possible forward bending which can occur during the gravitational force activity, and hence reduces burden on the muscles. Significantly, the reduces the burden on the muscles. If these cartilages are not able to function, then the burden on the muscles will increase and the muscles will become spasmodic. Now, all these would have some significance when it comes to the question of clinical presentation and examination later. Whereas the posterior ligament, it reduces the possibility of flexion of the vertebral body, and in the similar way, it also supports the same. Supraspinatus would be, it resists the possibility of spinal separation during flexion. So during bending forwards, there is a force which attempts to increase the gap between the vertebral bodies, but that gap force is neutralized so that the vertebral bodies do not get separated during the flexion by the supraspinous ligaments. Or if the supraspinous ligaments are affected, then during the flexion the gap tends to increase. Now once the gap tends to increase between the two vertebral bodies, there can be different possibilities as such. The different possibilities could be the intervertebral disc and that annular fibrous substances, they may get torn off or they may get displaced, which you call as the disc lesions or disc protrusions, or this gap may also affect the neural foramen and the nerve root could be compressed. So consequences could be many. Then the ligamentum flavum is the ligament between the two consequent spines as such, which maintains the tension of the disc. That disc is not allowed to get compressed. It is kept somewhat extended by the ligamentum flavum, the posterior ligament. The major muscles, of course, I will not go into the individual muscles as such. The muscles around the spinal vertebral column, they can be categorized into 4 groups based upon their functions, 5 groups, as extensors, flexors, lateral flexors and rotators, 4 groups of course, depending upon their functions, and each of these muscles have a major role to play in maintenance of the position against gravity. And from the clinical point of view, whenever there is a pathology of the bone, the immediate structure which would be affected would be the muscles. A good amount of the lesions related to the bone are borne by the muscles. They are made to clinically less active or less important by the muscles. So hence, when each one presents the clinical presentation, the examination of the muscles and the condition of the muscles is quite critical to understand the pathology of the bones. See, bony, it's true for any other area of the body, not only in the vertebral body, anywhere. When there is a abnormality of the bone, that abnormality of the bone or load on the bone is shared by the muscles, and the clinical presentation of the symptoms would occur earlier in relation to the muscles than that of the bones as such. Then the next structure which is of significance is within the spinal canal, the meningeal layers. The 3 meningeal layers, the dura mater, arachnoid mater and the pia mater. The pia mater, as usual in any area, is very closely adherent to the nerve structures, the spinal cord, whereas the dura mater is the outermost rigid structure. In between the dura mater and the arachnoid mater, you have the epidural space. The space is called epidural space, which contains some fatty tissue and vascular structures. Whereas in between the arachnoid and the pia mater, we have the subarachnoid space, which contains the CSF. Circulation of the CSF would be there. The spinal cord is not always has the same having the same length as that of the vertebral column. The spinal cord usually ends at the level of lumbar second vertebrae, and below that lumbar second vertebrae it's mainly the conus medullaris. Virtually the spinal cord doesn't exist. Instead, that the cauda equina, the nerves which are present like a horse's tail, they are presented over the area, and this area would not have the spinal cord in as elsewhere, and this is also has a significance from the clinical point of view. The epidural space is the space which usually ends up to the level of sacral hiatus, and hence you have that space here. This space is formed. The epidural space ends up at the sacral hiatus level, and it has having the vessels like the epidural space if in a cross section, whereas the subarachnoid space has a wider area, and there the CSF is circulating as such, and that is also a critical issue. The venous plexus which supply the spinal cord, they are located in the epidural space. Now subarachnoid space is very wide, comparatively wider in the lumbar spine area, and particularly below the lumbar second vertebrae, because there is no spinal cord, instead only the phylum terminal is there, and it's something like a sac containing fluid, like it is called as the lumbar cistern. The name is given as lumbar cistern. Anatomy of these subarachnoid and epidural space is quite important in the case of the anesthesia, regional anesthesia. When you inject the drug into the CSF, the needle has to penetrate through this space, which is a narrow space, and get into the subarachnoid space, so that the CSF will leak if it is the spinal anesthesia, or what we call as the subarachnoid anesthesia. If it is a epidural anesthesia, the needle should reach to the space between the dura mater and the arachnoid mater, where the CSF is not really leaked and CSF doesn't get punctured through, and the needle negotiation is by a blind process, and confirmation of the needle put in that position is done by only the feeling of the resistance when you push the air in. When because of the loose areolar tissue here, the air can flow through easily in the epidural space. So these spaces and their anatomy has a significance from the anesthesia point of view. Moreover, they also have a significance in terms of the healthy status of the spinal cord. The spinal nerve roots are formed by the cell bodies of the motor nerve fibers and the sensory nerve fibers as such. The anterior horn is having the motor nerve fibers and these form a dorsal root ganglion. There will be a ganglion formed at the dorsal side and it's very close to the neural foramen as such. That's about the anterior horn, the posterior horn, or what we call as the sensory. There would be a ganglion, and the ganglion of the sensory nerves would be formed outside the spinal cord, whereas the ganglion or connection between the upper motor and the lower motor occurs within the spinal cord at the anterior horn as such. So that's the situation there. In the spinal cord, you will have many columns or many segments, and these are making the grey substance, grey nerve cells would be presented in the middle of the spinal cord, whereas the white substances or white nerve cells would be presented in the periphery, and depending upon the connection of the nerves from which area to which area, based upon that they are categorized, they will be named with the different columns. Now that part, anatomy of the columns and their importance, will come to that in the later discussions. Now at present, just be limit to this whole issue. The dorsal ganglion, which is the same, which is formed by the sensory nerve endings which go through the dorsal surface. The anterior is the motor. In the motor area, the nerves which descend down, which form the nerve roots, then they again unite together, they form the mixed nerves which reach to the periphery. That's how the spinal cord is arranged. The segments, again, the columns of the spinal cord, either they are categorized as ascending or descending. Ascending in the sense which carry the sensation from the periphery to the higher centers, and based upon their location, the reaching area, they could be named as either the spinocortical tracts or which reach to the gracile follicles, or which reach to posterior spinocerebellar or anterior spinocerebellar, the nerves which reach to the cerebellum from the spine are spinocerebellar, or which reach to the thalamus, spinothalamic, and so on. They named after that kind of issue. More details of that we will be discussing when we go into the other diseases of the spinal cord later on. So that's in brief about the anatomy of the vertebral body. Now the most common clinical condition related to the vertebral body is vertebral column, and presented in the clinical practice is low back pain. Now low back pain is a very complex condition which can be produced due to multiple causes, and again it's primarily categorized into two categories, acute and chronic. So a pain which is persisting for less than 3 weeks is considered as acute. When it is presented beyond the 3 months, then it's categorized as chronic, which always suggests that there is a abnormality of a anatomical structure of the body. A functional pathology, a simple strain or so on, where there is not much of an organic pathology, would be presented, and it will be having a self-clearance or self-termination within 3 months of onset. So any condition which is beyond 3 months of onset, you can categorize as chronic low back pain, and it confirms that there is a pathological changes in the anatomy. Now, as I said, because low backache is a very common condition, and one of the most common clinical condition which is seen in any clinical practice, the WHO has given or released a special document on these as such, the low backache condition, and the key facts, the important facts published by the WHO is, as I just copied it as such, in 2020, low back pain has affected 619 million people globally, and it is estimated that the number of cases will increase to 843 million cases by 2050. And because the patient is the average age of the society also is increasing. Low back pain is a single leading cause of disability worldwide, and the condition for which the greatest number of people may benefit from rehabilitation. So, rehabilitation facilities are required to help the patients, as such as the rehabilitation techniques and all that we will be discussing in detail later. Then it can be experienced at any age, and most of the people, at least once in a life, almost every people would experience low back pain at least once in their life. Prevalence increases in the age of up to 8 years. The highest number of low back pain cases occur in between 50 to 55 years, and it's more prevalent in women. Non-specific low back pain is the most common presentation. When I say 90%, non-specific in the sense where you do not find any organic pathology. Now, as far as the causes for the low back pain and the pathological changes which are produced due to the low back pain, could be a huge number of causes can produce that. And we categorize them as either mechanical syndromes or neurological syndromes or metabolic syndromes and so on. The mechanical syndromes which are produced due to certain mechanical pathologies, structural pathologies of the vertebrae and the spine, could be discal or facet motion segment degeneration, where the facet joints affect, the movement of the facet joints affects, and hence the nerves may be compressed, or muscular pain disorders like myofascial pain syndrome, discogenic pain with or without radicular symptoms. Now, what we mean by that discogenic pain, that we will be discussing that in detail. The disc lesions, the abnormality of the discs would be the next chapter which we will discuss in detail. So, there we will discuss what we mean by radicular symptoms and so on. Radiculopathy due to structural impingement, that's if the gap between the two facet joints is altered, the nerve radicals could be compressed, and that's what we call as a radiculopathy. Or axial or radicular pain due to biochemical inflammatory reaction of the or spinal injury, mechanical injury or biochemical injury of the spinal cord or vertebral column. Motion segment of the vertebral osseous fractures, that's the fractures of the vertebral body which during movement they may produce the pain. Spondylosis with or without lateral canal stenosis. Now, spondylosis also is one condition which we will be discussing in detail. Macro or micro instability of the spine without radiographic hypermobility in evidence. There is a possibility of abnormality of the movement of the vertebral body even when it is not seen in the X-rays or in imaging. That's called as micro conditions. Then you have the non-mechanical syndromes like which are primarily neurological. There you have myelopathy or myelitis. Of course, myelitis we will be discussing somewhat in detail. Lumbar plexopathy, often due to the abnormality of the lumbar plexus, and polyneuropathy we have already discussed. The plexopathy and the polyneuropathy we have already discussed in the previous sessions. Acute, subacute or chronic polyneuropathy and Guillain-Barré syndrome. These issues we have discussed already. Neuropathy produced like causalgia is also somewhat which we have discussed. Myopathy or myositis, diseases of the muscles where there is a involvement of the nerves too. Then the dystonia of the spinal segment. Then systemic disorders also can present with the low backache as a symptom, and it could be either primary or metastatic pathologies, lesions, tumors can present with that. Epidural infections can present with that. Inflammatory diseases of the vertebral column and spinal cord could occur, or inflammatory pathologies of the vertebral joints, either the intervertebral joints or the facet joints could be presented with low backache. Osteoporosis also can present with that. Vascular disorders like atherosclerosis also can present with the pain in the low back as such. So, important is a patient of low backache has to be examined thoroughly to confirm the diagnosis. Low backache also could be produced due to the referred pain from gastrointestinal tract disorders like pancreatitis or pancreatic cancer, or cardiorespiratory disorders like pericarditis, pleuritis, or disorders of the ribs or sternum, genitourinary disorders like nephrolithiasis, or pelvic infections as a whole. Thoracic or abdominal aneurysms also can present in the lower backache pain symptoms or because of the referral of the pain. Hip disorders of the hip also may present with the pain in the low back area, which can be confusing as such. That's about the different types of the causes. So important is that every patient of low backache is not a single entity. It could be produced due to multiple huge number of causes, and hence a thorough examination is necessary. When a patient presents with the low backache, a thorough examination is absolutely necessary to point out which of the factor could be affected. So the series of examinations, the method or protocol of the examination also is quite in detail, and it has to be followed meticulously. The protocol of examination of the spine, vertebral column, particularly lumbar. Now we are now more focusing on the lumbar area than the other segments. Other segments we can discuss later on. So particularly in the low backache condition, when the lumbar examination has to be done, the protocol of examination is initially you have to have the inspection by observing the patient in the standing, sitting and lying down position. In the standing position, examination is quite important, where the spinal curves have to be examined, changes in the symmetry in the skin folds if they have asymmetry, and that again confirm about the possibility of irregular size or atypical sizes of the muscles there, or curvatures of the spine like kyphosis or scoliosis like conditions. Atrophy of the muscles, they need to be observed by looking at the bulk of the muscles as you see in these images. In the sitting posture also, the position of the body, either whether the patient is able to sit erect or whether the patient bends to any side or not. In the lying position particularly, muscle atrophy and leg length discrepancies have to be observed. Then the gait also has to be observed very typically. Abnormalities of the gait we have already discussed in the beginning of the neurological classes. Then more specific examination for the vertebral column, vertebral body, motions of the lumbar spine. The lumbar spine would have a forward range, flexion range of 40 to 60 degrees, extension range of 20 to 35 degrees, lateral flexion of 15 to 20 degrees, rotation of 3 to 18 degrees is the normal range of the movement. Now each range of the movement has to be examined to confirm whether any of the movements are restricted or not. If any of the movements are restricted, that has been noted, that can again help in making the diagnosis at the end when you put in all the inputs together. Then the muscle tone in isometric condition has to be done, examined, and it is done by hip flexion and extension with resistance. Make the patient lie down, flex the hip and extend, see the tone of the muscles. And with the resistance, when you apply the resistance, you can see whether the patient can flex and extend the hip against the resistance or not. Similarly, knee flexion and extension and abdominal crunch, like you have to press the abdomen and see the tone of the abdominal muscles to assess the possible changes in the muscles. Now, these changes in the tone of the muscles, isometric muscle tone could occur either due to the muscular pathology or due to the neuromuscular pathologies. Neurological conditions also can produce that. Now, that different conditions which can produce a change in the muscle tone, we will be discussing when we go into the specific diseases. Then the palpation of the examination would be alignment of the spines, whether the spines are aligned in the proper line or not. If there is any deviation, that has to be. The gap between the interspinous gap or gap between the two spines has to be assessed from above to below. In the cervical area, the gap is comparatively lesser. Thoracic area, it increases. Lumbar area, it's the maximum, and that has to be assessed. And consistency, like if there is any soft area or harder nodular area, that has to be seen. Tenderness over the area. Compressing upon the spines, you have to assess the tenderness. It's also often named as doorbell sign. When you put the sign, pressure over the spines, if the patient feels the tenderness at that spot, then we can say that there is some painful pathology at that area, or it could be like because of your pressure, the vertebral body can be somewhat displaced in the anterior-posterior direction. There is an instability of the anterior-posterior direction. Now, more specific tests done and which are quite popular are the straight leg raising test. Straight leg raising test can be done in two ways, by raising one leg or maybe both the legs up. Now, the interpretation of this is quite important. When you raise the leg up straight, when one leg is straightened up, the gap between the two spines, or that the facet joints, neural foramen area, that tends to get reduced as such. Whereas within the spines, intraspinal area, virtually there is not much of a change in the interspinal area. The meningeal structures would not be stretched, except partially the conus medullaris may be slightly stretched when one leg is raised. So, if a patient feels the pain, now normal range is the leg has to be raised up to 90 degrees where there will be no pain. If the patient feels the pain and raising the leg up, then it means there is some abnormality at the neural foramen area, which tends to get impinged, which is tending to get crushed as such. Now, when the gap between the two is reduced, when the leg is raised, that means there is a compression of the nerve root at that level. Now, when both the legs are raised, it again reduces the gap between these vertebral bodies on both the sides. Moreover, it also produces a slight compression of the intervertebral disc. Intervertebral disc tends to get pushed towards the anterior side. There is a bulging of the intervertebral disc because when both the legs are raised, the midline pressure would be there, and this pressure would be compressing upon the conus medullaris even slightly, and the conus medullaris also is stretched. So when both the legs are raised, if the pain is there, it could be due to the gap between the vertebral bodies, that facets are reduced. Moreover, it also could be due to the protrusion or disposition of the intervertebral disc. If the intervertebral joints have become displaced, both the legs raised will produce more pain as such. Now, this test also helps in differentiating between a intraspinal pathology and extraspinal pathology. If a patient has a pain due to the intraspinal lesion somewhere within the spinal cord, leg raising test would not aggravate the pain. Whereas if it is in the lateral column of the spine, like in between the transverse processes and the facets, then leg raising test would produce the pain. If the pathology is beyond the spinal cord and the patient has the pain as a symptom, then leg raising test would be negative. The patient has to raise the leg up, there will be no pain. There would be no pain if the pathology is within the spine. So when the patient feels the pain and raising the leg up, it means the pathology is somewhere in the lateral column of the spinal cord, or in between the transverse process and the facet area. Now, as far as the sciatic nerve is concerned, the sciatic nerve is originating from the lumbar segments and upper sacral segments, and when the range of movement goes up to 30 to 70 degrees, there the sciatic nerve would be stretched at the sciatic notch also beyond that spinal cord, and hence when the patient has the pain at the 30 to 70 degrees, it also could be produced due to the sciatic nerve involvement at the sciatic notch. Now, to confirm that, the other two options you have, one is a crossed SLR test, when the leg is crossed over to the other side, that can produce the pain, aggravate the pain, if the pathology is exactly at the spinal cord level, the lateral spinal level. Sciatic notch would not be affected. Suppose a patient has a pain on raising the leg up, to rule out whether it is a sciatic nerve or compression at the sciatic notch, or whether the compression is at the vertebral column area, one of the option is you cross the SLR, that raise leg is extended or abducted as such. If on abduction the pain aggravates at a level where the patient doesn't feel the pain, that means there is a pathology at the transverse process area. And if the patient doesn't feel the pain, the earlier pain felt was due to the compression at the sciatic notch area. The other tests which are done also, some modification of the same is what you call as a flip test. The flip test is the patient is made to sit straight and the leg is extended, and when due to as the leg is extended, due to the pain, if the patient tends to fall back due to the tension, it also could be due to the sciatic nerve which is stretched beyond the spinal canal, beyond the spinal process. Or another of the option of the test to confirm like whether it is a sciatic nerve which is stretched beyond the area of the spinal cord or not. If the other test is the Lessig test. In the Lessig test, you raise the leg up till the patient feels the pain. Now, when the patient feels the pain, you have a doubt like whether it could be due to the stretch of the sciatic nerve beyond the vertebral column or at the level of the vertebral column, the lateral column of the vertebral column. To rule out that this test is more dependable than the other two tests, you reduce the level of the leg to such a level that the patient just doesn't feel the pain. You got the point. You raise the leg up till the patient feels the pain and then slightly reduce the level so that the patient at this moment is not feeling the pain. Now at that position, you dorsiflex the foot. When you dorsiflex the foot, the spinal sciatic nerve would be stretched without affecting the position of the vertebral column. Now, if the patient feels the pain during the dorsiflexion of the foot, that means the pathology is somewhere here in between the spinal cord, the vertebral column, and the that tip of the sciatic nerve. If the patient doesn't feel aggravate the pain on dorsiflexion, then the earlier pathology was the lesion was at the lateral column of the spinal cord. That's how it has to be interpreted. So SLR test, a simple test, can give you a good amount of the information about that. Moreover, SLR test also has a prognostic value. Like if the patient has a pain at certain degrees at the beginning of the treatment, and after during the follow-up, if the level at which the patient feels the pain is increased or reduced, can give you an idea about the progression or regression of the disease. So SLR test is one of the crucial tests in all cases of the low back pain, irrespective of the pathology, and they have both the diagnostic value as well as a prognostic value. Then the other tests which are often done are the slump test. In the slump test, the patient is made to sit, one leg is extended and the neck is flexed. So during that condition, if the patient feels the pain, that space occupying condition, particularly if there is a space occupying condition in the spinal cord, particularly in the cervical area, then the patient would have a pulling type of the pain in the upper limb. If the patient feels the pulling type of the pain in the lower limb, the lesion is in the lower area, lumbar or thoracic segment, lumbar segment as such particularly. So slump test is often helpful to make out the diagnosis of the intraspinal space occupying lesion within the spine. If there is it could be anything. Like when I say space occupying lesion, it could be a prolapsed disc, it could be a blood clot, it could be a tumor, or so on. So the spinal canal tends to get narrowed and stretched, and that produces the pain. Or another of the tests which is often done is the femoral nerve traction test to confirm whether the lesion is related to the femoral nerve formation or not. And that is done by making the patient lie down in a prone position, then flex the hip as such. Now during that condition, because the femoral nerve is stretched, the patient would feel the pain, and or the patient also tends to raise the other leg up due to the pain. In that condition, it is confirmed that the femoral nerve area is stretched as such. The other tests which are done are the Schober's test. Schober's test is to confirm like the flexibility of the vertebral column is within the normal range. Now, if you mark 2 points at 10 centimeter distance, and when the person bends forwards, it should increase by at least another 50% to increase it to 15 centimeter. Now it's 10 or 15 is not an important thing. The issue is it should be, the gap should enhance by around 1.5 times than that of the earlier. If you point to make out any 2 points anywhere in the middle point, and when the patient bends forwards, the gap should be 1.5 the gap of the previous straight condition, which shows that the vertebral column is able to flex to the normal area as such. The other tests which are also quite critical are the one-leg standing test or the Sark stand test, where the patient is instructed to flex one leg at the hip and knee, and he is taking as a marching step. Now at this position, if the patient feels the pain, that suggests that the vertebral column is not stable, and the location of the pain at that level is confirm the lesion. Particularly this would be useful in thoracic spine pathologies, because the thoracic spine lesions, they are not really easily made out clinically, and in the Sark test it can be, or one leg standing test, that can be easily made out. The one leg standing test also is used as a parameter for physical fitness in sports medicine. If a person can stand in the position for more than 50 seconds, that's considered as a perfect fitness, and depending upon the time taken during which the person can stand on this position without wavering, also you can categorize the fitness as good, average, fair, or so on. The time duration, if it's 40 to 50 seconds, it's good, average is 25 to 39, fair is 10 to 24, less than 10 is poor. So in the sports medicine as well as maybe in the defense fitness etc., Stark test is also used as a criteria to assess the fitness. Stark test also is done to identify the lesions related to the low back ache as such. The other tests which are useful are the Patrick Faber test, which is including flexion, abduction and external rotation of the leg, and during this, particularly if the patient feels the pain during the abduction, it suggests that there is an abnormality in the sacroiliac joint. Sacroiliac joint is the target area, and that would be made out by this kind of examination. That is the other test. Then the other tests are the muscle stabilization test, which assess the muscle strength, and there again Trendelenburg test is the one. Simple issue. If you raise the leg up on one side, in the normal condition, the horizontal axis would not be affected. It can be maintained in the horizontal level. If the patient has an abnormality of the bones, then there is a tendency for the body to bend towards the side as such. Particularly this is helpful in assessing the integrity of the gluteus minimus and gluteus medius muscles. Then the other tests also would be quite important, would be assessment of the myotomes, lumbar to sacral segments. The myotomes have to be done, and the assessment is done by the hip flexion or hip flexion and abduction for L2, knee extension for L3, ankle dorsiflexion for L4, and toe extension for L5, and ankle plantar flexion for S1. These tests are done. The reflexes, particularly the Achilles and patellar tendon reflexes, are used for L4 and S1 segments to confirm like which of the myotome is involved. And the dermatome, of course, the sensory part has to be examined corresponding to the same L1 and 2S1 dermatomes. And the L1 dermatome relates the anterior lateral thigh, the L2 is the anterior medial thigh, distal medial thigh is and knee is L3, medial malleolus area is L4, dorsum of the foot is L5, calcaneal and foot is S1. So you have to go for the sensory examination as well as the examination of the muscles and reflexes wherever relevant to confirm the myotomes, and myotome testing is done. The other tests which are relevant in case of the low back conditions are Babinski reflexes to confirm whether it is a lesion related to the upper motor or the lower motor. Intraspinous pathologies would be presented as upper motor, where the Babinski sign would be positive. Babinski sign is by scratching over the foot in a direction from the heels to the toes in the normal there will be a flexion, whereas in abnormal, that's a upper motor type of the lesion, it will be the extension which is seen. Of course, the extension is normal in children as such, it is not abnormal. The other tests which are done are the open hem test, where if you scratch over the tibia, anterior tibia, the toes would be having a positive or abduction. The toes would be abducted, which suggests that there is an abnormal nerve response, particularly at the spinal cord level. It's an alternative choice for the Babinski upper motor. There would be many more tests which can be used as an alternative to the Babinski test, which could be assessing the plantar toe reflex, or which is actually the Babinski, or Chebyshev test, or Schaeffler test, or open Hims test, or Gordon's test, or Bing test, or Gonda-Stransky test, which also are just modification of the same, not very important issue. Among them, the Achilles tendon reflex is quite important. Squeeze hard on the Achilles tendon. If the patient shows the extension of the toes, that's suggestive of a positive involvement of the sacral segments as such, and that's called as Schaeffler's test. That's one of the important tests. That's about the examination of the vertebrae. So we'll conclude today. In the next, we'll discuss about the lesions of the disc, comprehensively, which we call as the disc lesions. Their pathology we will discuss in the next class. If there are any questions, no questions. So we'll wind up today. In the next session, we will discuss about the disc lesions, disc pathologies. Right.